Welcome. Welcome to Dr. Lani's Bone Health for Life webinar. And today I'm going to talk about bone health, and I'm going to talk about bone density testing, fractures, and a lot of good information to give you a baseline of what you need to understand in terms of bone and your bones. As we are learning more and more about bone, there is much more information out there and interpretations of that information. All of us have at one time or another or still are very confused. And when we have a diagnosis, how frightened do we need to be, or how mindful do we need to be? I'd like to try to switch it there. But I know, and I do want to say this, I mean, some of us who are diagnosed with osteoporosis, and I'm one of them. I was diagnosed in my 40s. I'm now 69. I've not had a fracture in my life, and I still have osteoporosis. But it's not borderline now. It's a bit more. It's a negative 2.8. But the point is, I've been able to stabilize my bone through natural methods and bioidentical hormones. I was lucky enough to be able to use them. And yes, I know some of you can't do that either. So each of us has a different set of bones, which is why you can't have a one-size-fits-all approach. That just doesn't work. And which is why it takes time. It takes me time to go over a case. It takes me time to understand an individual's bones. And that comes from doing a very extensive intake where people are filling out questionnaires, writing down everything they eat. I want to know what their poop looks like, their family history. I want to see x-rays if they have them, bone densities if they have them, MRIs if they have them. And who's going to take the time to do that? I mean, actually, I'm getting to the point where at my age now, I want to pass that kind of work along. But I think that's what's needed. If we're going to make decisions on whether or not to do medications, we need to understand that we're making the right choice and not just reacting out of fear. And, when I was diagnosed with osteoporosis, I was scared to death. I was in my 40s, and here I am, an athlete, and bang, I get this diagnosis. And I was teaching osteology and arthrology and spinal anatomy at college level, even before. I've always been involved in bone and love bone. And so I was at a friend's office in San Francisco, and let's just do a bone density. And there it was, borderline osteoporosis. And right away, the doctor wanted to put me on Fosamax. I declined. I knew I needed to learn a lot more before I pumped something into my body. And I'm not opposed, those of you who have read my book, who know my work, absolutely not opposed to wise use of medication. It's just that often what I see is inappropriate use of medication. Wrong medications prescribed, the right lab work, foundation work that has not been done to root out any secondary causes for osteoporosis. So, as I said, there's a lot to learn so that each of us feels confident that we have our arms around this business about bone health from a larger perspective. Okay, so I'm going to go ahead and start the slides. And bear with me a moment. Okay. There they are. Okay. Share. I get to share. Get rid of that. Okay. And I think you can still see me as well. But I can't see the box now. I know if there's any problem, Cheryl Edwards, I know you're on this, text me and let me know. But otherwise, I'm going to assume there's no problems. I'm going to go ahead and get started. Okay. Well, many of you know I have this book, and I spent 2 years writing it and many more years doing a lot of work around osteoporosis and understanding it. And I'm glad I did the book because it forced me to really look at the studies out there and the opinions and shape my own viewpoint. I was also lucky enough to get the PBS show. Some of you have seen it. By the way, I still have some of the material from that. I have there's a package that you can get, and I of course think it's really well done. You get the show, the 1 hour show plus 20 minutes of Q&A. And then I do one on exercise, recipes with Irma Jennings. And then I do one with Patricia Ellsberg. And this is around mindfulness. She's a mindfulness teacher. She's fantastic. And then also safety. And then an additional booklet that goes along with that. So I think that this is a very good package for people to really get get even more in-depth understanding about bone and what we can do about it. So our bones are dynamic. Bones are a reservoir of nutrients. 98% of our calcium is stored in bone. There's a whole lot of misinformation about calcium. Get all your calcium from food. Calcium citrate isn't absorbed. Calcium citrate is bad. Calcium carbonate, just take Tums. I mean, you can't have information that's more opposite. It's pretty incredible, actually. I will do an entire show on this because I think there's so much confusion around it. Do you take calcium with magnesium? Do you not? What about vitamin K? I mean, it's just, it's a lot, isn't it? And so I intend to do one on that very subject. And some of us, by the way, and I'm one of them, I do take supplemental calcium. Not a lot. You don't want to take more than 200 or 300 at a time, just like it would be in a natural food. But I don't eat dairy, and I don't want to spend my whole day eating food trying to get my calcium. So that's what they're for. That's what they're for. So our bones are amazing. I had the honor of being able to teach osteology from embryology through adulthood. And it's just bones are amazing. That's all I can say. Bones are amazing. And it's never too late to build healthy bones. So a lot of times I'll see people in the chat group. They are frustrated because their bone density didn't go up. It's not all about bone density. If you're eating well and dealing with digestive problems that you have, and sometimes, of course, things like Crohn's disease are not so easy to deal with, but if you're really working to resolve those things, you are benefiting your bone. So again, not all about bone density. Healthy bone is a living tissue. It's very dynamic in the body. It is full of, bones are full of blood. There's transfer of nutrients there, and they're just amazing. And our body rebuilds about 10% of our bone each year. That's how it stays healthy. And it stays healthy by, hang on, not sure where it'll come up, but it stays healthy by osteoclasts. Osteoclasts chew up bone, and the osteoclasts get rid of old bone. And so the osteoclasts get rid of old bone, and then the osteoblasts lay down new bone. So this is a process that goes on every year. However, as we age, that process is less efficient than it used to be. With the osteoblasts, when we're younger, it's like, in fact, it starts at 7, about the age of 7, where our bodies start, repairing and getting rid of old bone and laying down new bone. And what impacts bone health? There's hundreds of things that can impact bone health, but these are kind of the basics here. Digestive health, I have that at the top because I think that is absolutely central for our health, our bone health. Mental health, if we're depressed, depression can lead to perhaps bone loss. And what about the medications for depression? Again, that's another complete topic I'll be dealing with. Physical health, mental strength and flexibility, digestive health. Oh, I've got that twice. That's really important. Balanced macronutrients, proteins, carbohydrates, fat. And, you know, the thing is that there's so many, again, bad recommendations when it comes to diet, or people become fanatics. I don't know if you know what I'm talking about. It can go anywhere from, I live in Berkeley, California, but paleo to vegan, and they're all in the same block over here. So not saying either one is wrong. I'm just saying that I think you get my point. So as a chiropractor also, uninterrupted nerve flow. We want to make sure that our spine is flexible, that the nerves are healthy, and I'm a big fan of chiropractic care as well as acupuncture. Hydration. We don't give that enough credit. And hydration is important for our bone, important for our muscles. It's important for brain function. One of the causes of depression is dehydration, or can be. So bone through the ages here. You can see that as we are, hang on one second. I want to get another little spotlight thing. Oh, I don't know how to do that. Oh, there it is. I figured it out. Okay. So effects during bone through the ages, you can see how quickly, how things rise in our early years for both men and women. And then peak bone mass. Men arrive at a higher peak bone mass than women. Then it flattens out for both. Men have a slow decline. Women, look at this. Bang. That's menopause. Now, let's say you have a small woman, like myself, 115 pounds and 5'5". And if this woman does not take hormones, she's going to be at a huge risk of losing more bone. She already has small bones. Small bones are going to break bigger, easier than big bones, period. We want to stop this if at all possible. And yes, I've dealt with a lot of people who have breast cancer. So I get that part too, and that's a different conversation. But I'm just saying that that's what happens here. So osteo means bone, porous, void spaces, osis condition of osteopenia, low bone mass. They never should have put this diagnosis on a report. That said, I'll talk about that a little bit more, but there is use for that for sure. And I will share that with you in a moment. Oh, I lost my little thing. All right. So this is dense bone versus osteoporotic bone. You can see in this image here, bone is nice and filled in, and here you're seeing holes. And the next image shows normal and a different view of it in osteoporosis. And if you lose this infrastructure to a huge degree, there's nothing to hang calcium on. So when you start getting into the negative 3.5, -4, -4.5 T-scores, that's serious, and it should be taken seriously. And by the way, what fills in, I'm going to ask you guys this question later, but what fills in these areas where we don't have bone anymore? What's there? And this is something that we see this picture in books, and it shows this woman at 35, 55, 65. I'm 69. I don't look like this. Some people at 65 do, who have very advanced osteoporosis. I've been fortunate. I have not had fractures. But also, I don't want people to think that this is the progression of things. It is not. This is a very serious case. And when people have this kind of thing at a younger age, something is wrong. Either there's a genetic component or, parathyroid disease, primary hyperparathyroidism, kidney problems, Crohn's disease, digestive problems, malabsorption. So a lot of different things. But my point is, you don't get like this unless there's a problem. You don't get to a -4 or a -4.5 T-score unless there is a -3.5, unless there is a history of some problem. Maybe, like me, you didn't do your teenage years very well. By the time I was 18, I wasn't doing those years very well. And we're building up 80% of our bone mass by the time we're 18. So I was busy smoking and eating a lot of sugar, just not building up that good bank account. So bone is silent. So we don't really think about bone unless something is wrong. Healthy bone is essential for us to maintain our physical independence as we age. So that's an important thing to understand, is that it is about our physical independence. That's why we get so frightened with this diagnosis. I hope you all have some tea that you're sipping on this morning. Nettles tea or oat straw, something good. And now I don't do it all the time. Okay. Dual energy. So we're going to talk about bone density. There's 3 machines: Hologic, Lunar, GE, and Norland. I rarely see Norland anymore, and I prefer people not use Norland. Hologic or Lunar, and you want to get the same machine if possible. You want to go back to the same exact machine. And when you go into the facility, you want to ask them if it's the same serial number. A lot of these places have more than one bone density. I've been seeing this a lot lately, especially at hospitals or imaging facilities. And they don't care. They're not putting you on the same exact machine. If you're on, I won't get into it, but the point is, we want to ensure that we're going to get the best possible bone density. So it makes sense to use the same exact machine. The areas that are tested for bone density are the spine, the hip, and the forearm. The reason we use L1 to L4 is because we can see through, the image can cut through there, and ribs are not in the way. And we don't use L5 because the sacrum's in the way. So people say, well, I have osteoporosis in my low back. No, you have it throughout the spine, most likely. So it's just that we don't test up there. And there are some facilities that are testing up there, but I can tell you that they don't have a database for that that's of any value. So it's the L1 to L4 region. Sometimes they'll delete one. I'll get into that a little bit. And then, and because it's off, there might be something wrong with that bone. The hip is, we test bone density in 2 areas: the neck of the femur, right here, and the total hip, which includes the neck of the femur, greater trochanter, and down in through here, the intertrochanteric area. So the total hip is this region, and the neck is here. Some people think the neck means the neck, like your neck, but it doesn't. It means the neck of the femur. Now the forearm is the one that we test, actually is right up, well, we test the whole forearm, but for diagnostic purposes, it's the 33% area. This is a different type of bone. It's compact bone. I will get more into this, and next month I'm going to be doing a whole thing on bone density testing, and so that you guys can look at them yourselves and tell whether or not the basic whether there were errors made. And I can tell you, you'll be able to see them. So we will go over those. So the mid forearm is compact bone. The lumbar spine is more cancellous bone. You can read about this in my book. This area down here is the ultradistal radius. I look at that too, but it's not a diagnostic area. So again, the diagnosis of bone density can only come from 4 places: the lumbar spine, neck of the femur, total hip, and the mid forearm 33% area, or it's also called 1/3. But as a densitometrist, which I am, I'm a clinical densitometrist, I glean information from all these other things, all these other areas that I can put into good use to help determine somebody's their bone health. Like there's something called wards. Well, that actually gives me a big tip, but a lot of the times they're not even in the reports anymore. But again, that's something we'll go over when we have time in a future webinar designed to go through these. This is a bone density. This is how you should be set up for your hip. There should be this internal rotation. This image is in my book. And the internal rotation, when you have it, puts the neck of the femur at the lowest density. That's why we do it. Some places don't do it, and they still get it right, but you're going to mostly get it right if you actually use the block. It takes time, so a lot of places aren't doing it. And here we're showing all 3 areas, the lumbar spine, and it's better if your feet are up on the blocks, but I can tell you a lot of places are not doing it now. I can tell you that like I say, they may not do this, and there's just nothing you're going to be able to do to change that. A lot of times on GE equipment, they're just not doing it. But this is the best way to flatten out the back and get the best bone density in the spine, period. And then here's another gadget where they use, different places might use different ways to get that internal rotation. And the forearm, a lot of times they don't use these straps. I think that's okay if the person's really trained, they probably don't need it. But anyway, so in here is an older hologic equipment, and they are in position here. A single bone density does not mean that active bone loss is occurring. Bone density comparisons and lab tests help to establish if bone is stable or if bone loss is occurring. So bone density comparisons and lab tests help to establish if bone is stable or if bone loss is occurring. This is a big deal to understand. If you get one bone density, you don't know if you're losing. Maybe that whatever you got occurred when you were in your teens. And you want to know if you're actively losing, so that you begin to look for why. And there's a whole host of lab work. Some of them are standard. I will have a whole webinar on lab testing. Some of them are standard, and then depending on the person, I may have to delve more into thyroid. I may have to delve more into and repeat parathyroid and calcium and ionized calcium. So diagnosis is detective work, good diagnosis. So just to get some review for some of you, but BMD stands for bone mineral density, SD standard deviation. And one standard deviation, depending on who you read over the years, is between 10 and 15% bone. No one believes it's above 12 now. The machines are set at 12. So 12% is one standard deviation, and that's what we should stick with. I even saw, I think over on American Bone Health, they said 10%. I was shocked about that, but it is 12%. And there's no test that's perfect, but I can tell you, bone density tests give us one big piece of information without question, especially when it's done right. T-scores, So we're measured up against normal controls, 26 to 29, woman or man. And the Z-score is age match. So a lot of people think, oh, we should be looking at age match. No, we shouldn't be using an age match. I explain this in my book, but we use the Z-score for men under 50 and for women who are premenopause. So a woman who is postmenopause, regardless of age, we use the T-score. And for men, we use the T-score if they're over 50. And this is because the studies just don't have enough to support using a T-score for men, say, that are younger. And that's all that is. I always look at the T-score. But that said, it's important, obviously, to understand what this actually means. So one standard deviation is 12%. And adults are measured up against that young normal control. And what we know is that the further we move away from that young normal control, the more there is a chance of having severe osteoporosis. So we don't want to have a significantly lower bone density than an average 30-year-old. There's a lot of ways to think about that, but that's just a general thought about what that means, okay? So we are measured up against a normal 30-year-old. My bones are going to come in a little bit, smaller or a little bit less bone density because I am a small boned person. My wrists measure 5 inches. That's teeny. So I want to be careful that I understand what the bone density means to me. And by the way, they give it kind of like a 1 standard deviation or better to call that normal. So low bone mass or osteopenia, -1.1 to -2.4. Osteoporosis is -2.5 or lower, which means -3 or negative. I know it's kind of hard to think it through sometimes because it seems counterintuitive. And established severe osteoporosis is osteoporosis plus fragility fracture. But you know what? If somebody has a fragility fracture, say of the femur or the humerus, and they didn't have much of a fall or anything, that, regardless of bone density, that is severe osteoporosis because that would tell us the bone quality is not good. So I do have people who have normal bone density and they have horrible, severe osteoporosis. The good news is these things can be turned around when people get the right diagnosis and they're treated properly with nutrition, gastrointestinal support, and yes, appropriate medications when it's significant for sure. So here's a bone density, and this is a hologic machine. And here we have the model. And you always want to look at this because the model gives us a sense that, hang on one second here. I kind of lost my train of thought. I just got a text from my assistant. But anyway, we want to look at this to see, this is the serial number. So then you know if you're on the same machine. That's a good thing to know. And again, I'm going to have a whole webinar, probably 2, on how to analyze these things. But you always want to get a box or at least a page that has these headings. Look in the back of my book. When you get a CD and or hard copies from the facility, it should look like a little x-ray. If they put on CD, you're more likely to get that. But you want the area included, the bone mineral content, bone mineral density, T-score, Z-score. You want those headings on top. So that's what we want. Now here is and this is common, you'll see it like this. I prefer to see images on a page, but this is GE, And you'll notice that they, well, if you looked at them, compared them, they have a different way of analyzing the hip. Both companies do this the same way in terms of where they draw the lines, but the hip is done differently. And I like the way Hologic does it better myself. This is a vertebral fracture assessment, and this is good for people who, if there's a thought that there is a fracture or possibly that, get a baseline. It's much less radiation than x-rays, and all this is not a diagnostic anything other than to look to make sure that the front of the vertebrae are not fractured. That's what we want to know, because sometimes you can't tell. It can be hard to tell, even for someone like me who's steeped in radiology, to tell if one's new or old. There are ways to tell if it's new, like say within the last 6 weeks, but if it's older, it's hard to know, well, was that 6 months ago, a year ago, or 5 years ago? And this is a Hologic, just to show you how they line up theirs. I like how they do this rectangle. So this is where they do the hip, and this is the area called wards. I'm not going to get into that now. And then when they do the total hip, it includes this area, all the way down to where this bottom line is. That's the total hip. Now, GE Lunar, if you've had that machine, you can get ancillary pages for the hip and also for the spine. I like to get that. It gives me a lot more information to sort out all these different areas, tell me something different as a densitometrist. So you want to make sure you get those ancillary pages. They don't have that for Hologic. They do have an extended lumbar report you can ask for. Now, the trabecular bone score is something that is, I think there's probably only 10 facilities in California that have it. But it gives us different information. A good trabecular bone score, this one is 1.360. That's decent. I mean, it definitely is good. That's where mine is right now, and I'm 69. And then there are more, so it tells us about degradation, hence bone quality. So it gives us a tip off on it. Is this exact? No, it can be as much as 15% off. No tests are accurate, really. Well, okay, some are, but I still would redo them. I always redo tests. Well, not this one so much, okay, lab tests I'm talking about. But the point is, I know how to look at these individually, these bones, and come up with what I think is a good quality score. So when you get the whole picture didn't show here, but when you get the trabecular bone score, it's taken off of the lumbar spine only. And you have to ask a facility if they have it, because not all do. And on my website, you can look up in the search bar trabecular bone score, and you'll come up with a list of facilities that are known to have at least had it at one time. That might help you acquire it. And call the bone density facility that you had your last bone density done. Maybe they have it. Your doctor didn't order it. A lot of doctors don't see value in it. I see a lot of value in this test. So what is considered an osteoporosis-related fracture? Breaking a bone after falling from a standing height, or a non-traumatic fracture such as sneezing. So we can pretty much all agree that those are not normal. And rib fractures, I get a lot of people with rib fractures. They're bending over, pulling up a ski boot, or doing some other thing. It's not normal. It's not normal. And that can be giving us a window into the health of their bones. Keep this in mind. 90% of hip fractures occur because people fall. Most injuries happen around the home and inside the home. So we really have to pay attention. My booklet that comes with the PBS package And you can email about that at my website if you want to get that package. Has a booklet on that, because that's how important it is to make sure that your surroundings are safe. What leads to weakened bones and fracture? Hormones, balance, imbalance, poor nutrition, lack of exercise. So if we have all, these types of things, all these different types of things and more can lead to weakened bones. The shape and the architecture, the bone mass, material properties, bone strength, that all goes to bone strength, doesn't it? And then, of course, falls, muscle strength and balance, soft tissue padding. So if we have good muscle strength and balance, we're not going to fall as much, are we? So a lot of different things play into how we fracture or when we fracture a bone. Those who have good muscle tone tend to have better bone quality. Sarcopenia, muscle wasting, and severe osteoporosis often go hand in hand. So we want to keep our muscles strong. We want to think about, how do we reduce fractures? Keep muscles strong too. Balance, mindfulness. You can't minimize how important mindfulness is in terms of reducing fracture risk. Digestive health in our bones. Are you absorbing the nutrients you take in? Big question. And this is from my book. I just think that the digestive system is just amazing. It ever works, frankly. And here we see the stomach, and I'm not going to go through all this, but isn't that beautiful? It's beautiful, really. And that it works, and that it does what it does. It's just astounding. And then my wonderful illustrator did this for me for my book, and I just love it. And it shows where different nutrients are absorbed. So if we have sickness or in part of this is the small intestine, or if we have some of it taken out, we're not going to be absorbing all these nutrients that are supposed to be, absorbed in that area. And then we have the fat-soluble vitamins, which are absorbed in this area, and some in this area, and some in this area. So the body tries to kind of move it around a little bit, but the point is that we have to keep this healthy. So fat-soluble vitamins A, D, E, and K. You have to have fat. Turmeric, that's true about turmeric too. You have to have fat in order to absorb them. So digestive disorder symptoms, there are many. The last thing I want to hear from somebody, because constipation, for the most part, is easy to solve, but loose or watery stools, that is an indication of malabsorption, straight up. And I've just worked with people over the years regarding digestive issues, and most can be resolved. Got to know your poop. You just do. If type 4, we would all like to have that nice type 4. Sometimes we might get type 3. That's normal to get it occasionally. Type 5, it's still considered normal because it has clear edges. But fluffy pieces with ragged edges, that can indicate that a malabsorption issue. And clearly we don't want to get the rabbit pellets like this. We do damage to our colon if we're constantly and chronically constipated. Often it's resolved. People are taking too much calcium, not enough magnesium, not enough fiber, not enough prebiotics, probiotics, not enough water. I mean, just there are a lot of different things, hypothyroidism, a lot of different things that can be causing problems with the stool. And one thing I do want to show you, because I think it's cool, is celiac disease. We hear a lot about it. If we truly have celiac disease, what happens over time, due to the constant battering of the villi in the small intestine, these villi increase the surface area. These are all nutrients here, all these colored things. It increases the absorption. Well, look what happens over time. The villi flatten out, and now you end up with what we call functional malabsorption issue. We used to think these puppies would grow right back. They don't. That you will get some of them growing back, but if you have severe gluten issues, you're not going to get it all back. I don't have celiac disease, but I actually had my genes tested. There's 2 genes, and I have both genes for it. And guess what? Those genes can turn on anytime. And then I think, well, why would I even want to eat gluten if I have both genes? So I don't. On rare occasion I will, because it doesn't bother me to eat it, but it bothers me. I think most people, frankly, do better without gluten anyway, or breads of any kind. I mean, I would minimize that. But the point is, that's what celiac disease looks like. Okay, so I'm going to end there with the presentation, but I do want to talk a little bit about my masterclass because I'm developing it now. I'm getting super excited about it. I want to share with you what's coming up. And it is $35 a month to be part of this group. It's going to be a robust group. I will take Q&A in just a minute. My first thing will be actually this coming Wednesday on the 9th, but it's on my website. January 16th, I'm going to be doing Fractures, Facts, and Fears, Part 1. There's a lot you need to know about fractures. You don't want to figure things out if you're in the emergency room. There's a lot that you need to understand about fractures. How bones fractures, what you may need to do, what you may need to push your doctors to do. There's a lot to know. Bone density testing, Part 1. That may go Part 2 and Part 3. I will be teaching you how to read your own bone densities. I will also be sending out my interpretation of many studies. They'll be in videos so that the study will be there. And some of you have seen me do this, and I go through the study and give you my assessment of it and what my thoughts are about it. And upcoming speakers that are already announced, Kate, I'm not going to try to say her name. She's the one who wrote Vitamin K and the Calcium Paradox. I'm going to be very interested to learn about some of the new research and whether or not, in fact, MK7 is as good as MK4. And Diva Boone, who is an amazing, we've been having conversations via emails about vitamin D because I'm writing a book that's mostly on that now. And Jennifer Schneider, who, and Diva Boone is one of the top parathyroid experts and surgeons in the country. Jennifer Schneider was responsible for getting the black box warning on bisphosphonates, and she herself had sustained a non-traumatic femur fracture from taking those drugs too long. So it'll be an interesting, all of these I'm going to be really excited to do, and I'll be doing a lot of these on my own as well. So if you want to join, now's the time, because you will get a free signed book when my book comes out in the summer, Dr. Lani's No Nonsense Sun Health Guide. And it's about vitamin D. It's about supplement vitamin D. It's about how calcium and vitamin D and the parathyroid work together. It's about skin cancer. It's about the sun. Because I've had a lot of skin cancer, so I also want to share that with you because there's a lot to know about that too. Sunscreen products, that'll be in the book. It's a guide. And I'm very happy about circadian rhythms. I have a whole chapter on circadian rhythms and the importance of understanding how light impacts our health and our bones, by the way. Okay, now let me get back over to, hang on, I gotta unshare. Stop sharing. And now I need to figure out how I can see the chat line. Hang on, everybody. There it is. All right. All right. So, okay. So I'm open for questions. And go ahead and shoot some questions over. Oh, things are cooking now. Okay. So, Amy, you're asking which is better, MK4 or 7? Well, I think you should tune in, when I work with Kate, when we're doing that webinar. MK7 has a shorter half-life. Well, it has a longer tail, excuse me. So it'll last in the system fine. MK4 is where all the studies were, and that's where the drugs were first used for that particular substance. And what I need to do, and this is why I invited Kate to do a webinar with me, I want to go through, because this is really important. Vitamin K2 is super important, not just for our bones. It actually stimulates osteocalcin in the bone, which stimulates osteoblasts, but it also is good for heart health. So it, in a very simplistic way, helps get the calcium where it needs to go, into the bone and not our arteries. But which is better, and should we be doing both? So that will be coming. What test do you take to find out about gluten sensitivity? They're in my book. There's a number of tests, the gliadin tests you want to do, and the immunoglobulin tests as well. And there's some other tests. The genetic testing is different. The best way, if you're ever getting an endoscopy, where they're going down and looking into your stomach for any reason, ask them to do a biopsy in your duodenum or duodenum, depends on how you pronounce it. But they can go down and actually snip part of it. And that is really one of the best ways to determine whether or not somebody has celiac disease. Because they can look at the lining, and that's what they want to be able to do. And what form of calcium should you take if you need a supplement? Well, what I do is I get powder calcium, and I use a citrate. And I use, but I got to teach a seminar on this, and some of this is in my book, Understanding Elemental Calcium, Absorbability of all of these. And while it does appear that citrate, because there's more citrate, if you will, than actual elemental. Some people think because of that you're not absorbing it, but that's not true. It's better absorbed. But with calcium, you just don't want to do more than what you need, and you don't want to do more than 200 or 300 at a time. I usually do about 200, and the reason I do it is because I don't eat dairy, and I don't eat a ton of food. Nettles, you can get a good amount, not as much as what I previously stated in one of my articles on my website. But the point is, you can get a good amount of calcium through food, and most people can get enough, especially if they have dairy once or twice a day. You can definitely get enough. Is it possible to improve your bone health even though your T-score is advanced osteoporosis? Yes. You can improve your bone health at any time. And I don't want you to think you can't. But if you have advanced osteoporosis, that would say that medication should be a consideration, or that there's some underlying problem that has not been figured out, or maybe you do know what it is. But eating well, digesting well, and mentally really working with your mind absolutely will help your bones. And of course, exercise. And some people are very limited in terms of exercise. I understand that. But yes, you can affect your bones in a positive way anytime. Whether or not, will you reverse a serious condition like, say, negative 4.5? No, that's not going to happen. Will you reverse a situation where you're fracturing easily just through nutrition and GI health alone? No, you're probably going to need a combination. And that's what medications are for. I mean, if I get a heart attack, I'm not going to go to my chiropractor and get an adjustment, or go to a acupuncturist and get needled. I'm going to the emergency room. You know, medical doctors, and I know a lot of people who follow me. I mean, they follow me because I'm an alternative doctor, but we have to know their place. And when there's an emergency or a very serious condition, of course, Western medicine can be huge. Would it be worth pursuing the correct, let's see, rotation? I don't know what you mean by that. Kathy Lamb. What do you mean rotation? I don't know what you mean. Is a negative 2.9 T-score in the lumbar region at the age of 55 a reason to go on medication? Not necessarily. And if you can take bioidentical hormones, and there's a whole chapter on that in my book, that's what's kept my bone very stable. I still do low levels. But depends on menopause. If you went into menopause at 52, you're still losing. And you need to understand if you're actively losing. So negative 2.9 tells me, okay, you have a negative 2.9. But are you actively losing? Because if you are, and you're losing, say, 2 or 3% a year, the discussion in 5 years from now is going to be very different. Best exercises for osteoporosis in the spine. That's going to take a whole webinar. You know, I use bands, I use free weights. I think machines are good, but you got to know what you're doing. That's the bottom line. Pilates, people who've been trained with osteoporosis to devise a program for you. Now, I've never had fractures myself. I can do a pretty robust program. Some people can't. So if you really don't know, I get a lot of women, by the way, who have not done exercise in their life. Now they have osteoporosis, and now they're going to do exercise. That's scary to me. You really need to be working one-on-one with someone, make sure you are mechanically doing things correctly. And I will be doing, again, a webinar on this. You want to learn, well, to give you an example, if I'm moving, let me get the right position here. If I want to work my bicep muscle, this part of my arm isn't going to move. It's this part. You see people in the gym, they're swinging like this. That's not isolating. You want to be doing it like that. So in future webinars, I'm going to be going over isometric exercises and using bands, you know, getting a decent program going at home, but also talking about yoga. I'm a former Iyengar yoga teacher, and I'm really big on doing things correctly. Okay, so would it be worth having another bone density test done sooner than 2 years? Oh, good question, Kathy. If the test done 3 months ago didn't position my legs correctly, you know, I don't know. I'd have to look at your bone densities, which I do, by the way, for people. I analyze them, but sometimes it's just that they might not have positioned them correctly, but if they make the same mistake again, in other words, that not doing the rotation, I'm okay with that as long as they do it the same way. I can kind of determine about what that difference is, because once you've had a bone density, now it's about comparison. This is the kind of detail you're going to get in the Masterclass. But it's, you know, getting a bone density in a year, sometimes I order that. If someone's just had one bone density and they have significant osteoporosis, or I know they're losing bone because I've done lab work tells you that, I might order it in a year. But typically, if people are stable, you're not going to get something beyond what we call the least significant change unless it's 2 years and done correctly. And that's where we get into trouble. When you have one bone density, you're probably right in the ballpark, unless they've done a horrendous job. Yes, I see those cases. Most of the time you're in the ballpark. But it's the comparison. If they don't do that exactly the same way, then it can show like, oh, you've lost 5%, or you gained 5%. Oh, these drugs must be working. You've gained 5%. No, they placed the lines incorrectly. So, okay. Okay, so you had your ovaries taken out in 2012, Amy, and you lost 4.7% in 2 years in your spine, I assume. Yeah, I mean, your case needs to be handled, again, properly. If hormones can be done, that will stop that loss. But if you can't do hormones, you have to be on a very, very progressive nutrition and supplement plan. And most of that is in my book, but obviously when I'm working with somebody individually, that, you know, different things come up in terms of what I would do with them. How many months will the Masterclass continue? You can stay in the class as long as you want. But I'm thinking that I'm going to continue it at least a year and possibly longer. Each month we're going to, like this month in February, we're going to be looking at fractures. So people will read that chapter, and then I'm going to be adding a lot more information that's in the book in terms of fractures. When you write a book, you could only put so much in. I think my book would have been 2,000 pages if they would have let me go. But, and also new stuff comes up. So I'll be talking about that. But still, my book, by the way, I feel, I mean, there's nothing much I would change in that. The basic information on all of it, the medications, is still the same. There have been a couple more medications I didn't have in books, such as Timlis and the anti-sclerostin drug that just came out, which I'll be talking about when I do the one on medications. Yeah, it's hard to understand me when I'm chewing on a lozenge. I'm sorry, but if I don't do this, I'm going to be coughing. So I apologize for that. Minerals are difficult to obtain through food. Do you take supplements for minerals? If so, what type and dosage? Well, again, this depends on your diet. In my case, I do an extra 300 a day of magnesium and glycinate, magnesium glycinate, and you have to be careful with how much magnesium you're doing of any type, because for some people they're sensitive to it and you can end up with loose stools, which we don't want. But the magnesiums that are typically going to do that are magnesium citrate, and don't take magnesium oxide. Magnesium citrate can also cause loose stools in some, or some people react to the citrate portion. So glycinate would be the best form. Okay, so what lab tests can tell if you're losing bone? That's bone markers. You're going to have to look in my book about that. But again, I'm going to be going over labs in a future webinar in my new group. You asked if you pay for the class monthly. Yes, it is a pay for the class monthly. You can stop at any time. But it will be, like I say, a robust program. I'm going to be dealing with things even like sinus infections, all kinds of things that many of us are plagued with, hypothyroidism. All of these conditions ultimately affect the bone. So if you go to my website and read about it, you'll see all the different topics I intend to address either by a live webinar or I'm going to be making videos on and all of that. Some medical doctors believe that it is only needed about following medications. I'm not sure what you mean by that, Berta. I think you mean that the only way to deal with osteoporosis is through medications. True. There are a lot of doctors I know who would not give somebody who's never had a fracture medication if they're a negative 2.5 or a negative 3. But negative 3.5 and lower, you have to then begin to look at, and especially if a fracture is involved, what are the benefits of not doing it, or the risks of not doing it. So there, again, a lot of different things you have to put in the hopper before you make your own decision. Can you be on Forteo and still start hormones now? Would that help further? Yes, actually, a lot of people do that. In fact, I have some patients now who are using hormones following Forteo, because the whole point is making sure that the bone markers are not showing that active loss is creeping up. That's why you have to take another medication after Forteo usually. But there are, down the road, there's going to be much more sophisticated ways of dealing with all of this, and looking at tune-ups, for instance, if one does Forteo. Right now, you can take it for 18 months to 2 years. But it does an amazing job in that time. It removes old bone, lays down new bone. Doesn't get better than that. Your gynecologist, this is for Kim, and this will be my last one. Your gynecologist prescribed Evista. I have not taken it. Your thoughts on Evista? My thoughts haven't changed since I wrote my book. Although I have to say, when I do, and that's why this is good for me to do this series. When I do the series, the webinar on medications, I'm going to definitely delve into all new studies that have relevance. But Evista has side effects too, and it has a minimal impact on the bone. But it can be helpful to keep you from actively losing much. But I'm, in general, not a fan of Evista. And then Larissa, you asked, what's the best way to get off of Prolia? You need to work with someone who knows what they're doing. Depending on how long you've been on it, I think you understand that there can be fractures. People get fractures when they stop it. How big a percentage? Not big, but they do. And I suspect if we even sorted out who sustained these quote unquote rebound fractures, it would be people who probably had sustained fractures before. I don't know that. That's the kind of stuff I've got to sort out when I do the webinar on it, because this is all new in the last several years. So Prolia has the same black box warning. And by the way, when Jennifer Schneider comes on with me, we'll be talking. And when we do that webinar together, she's all over this information, because she is one of the ones responsible for that black box warning. So we will be looking very much at the Prolia and the bisphosphonates. Okay, well, I want to thank everybody for joining me. Sorry I had to use this lozenge, but my throat's a little scratchy. And I look forward to working with all of you and in the future. So I hope some of you decide to join my masterclass. And again, you can stop at any time, but February is going to be really good. All right, take care. Bye-bye.